All right. So the one we missed is just the ways. It's just a review of our physiology on how we generate and lose heat. Let's start with hypothermia first. The definition of hypothermia is what? When are you considered hypothermic? What's the temperature?
When it goes below 96.8.
All right. These are the risk factors. So this question here will answer which of the following are risk factors for hypothermia? Select all that apply. All right, so here we have older adults and then young children. Mental disorders or psychiatric problems can also cause that, namely dementia or people with cognitive delays, for instance, or impaired individuals, not necessarily having psychiatric problems, but altered mental status, okay, due to alcohol or drug use, or certain medical conditions that affect either your sensation, your sensory ability, or metabolic conditions like thyroid problems, for instance, or poor nutrition, or poor nutrition doesn't only mean you're malnourished or underweight, but also obesity. Others like stroke, for instance, so anything that will impair sensory motor function. Okay, so these are all your risk factors for hypothermia. And since they're listed under hypothermia, then it'll be also vice versa. So this will be the same risk factors also for hyperthermia. So we have different levels here. Hypothermia is considered 89.6 to 95. And we go moderate, 82.4 to 89.6, and then severe, less than 82.4. You're pretty much a popsicle at this point. Please read the manifestations on your own. The patient's presenting signs and symptoms. Is our exam next week?
No, it's in 2 weeks, Professor.
Okay, all right. So please read the corresponding signs and symptoms. Okay, what will be the patient's presentation if they reach these temperatures? Okay, I won't read that for you. Diagnosis, of course, is, you check the temperature and that's it. You check whether they're hypothermic or hyperthermic. As far as management, you always consider what caused it in the first place. Okay, of course, we have standard treatments, especially when it comes to emergency treatment at the scene. So most of these conditions are outside the home, with the exception of heat exhaustion or heat stroke, which can happen inside the home. But most hypothermic episodes happen outside, unless, of course, we're dealing with a patient who, let's say during winter, they didn't have adequate heating. Either they couldn't afford the heating bills, or maybe their heating in the house broke down, right? So these are possible causes, but we always consider that most of these patients are out there in outside, usually in there's a outdoor condition involved here. Treatment will be standard, like I said. We warm the patient. There will be some exceptions with the rule here as far as when the patient already has frostbite, okay? But we'll discuss those separately. So the patient who is hypothermic, of course, we warm them. So just like with what we did in malignant hyperthermia, where we were cooling the patient inside and outside, we will also do the same in hypothermia. So especially with severe hypothermia, the patient will be warmed internally and externally as well. There are a few principles that we will follow, especially when we're dealing with moderate to severe hypothermia. So please read the passive and active rewarming here. So again, similar to what we did in malignant hyperthermia, the opposite happens though. So instead of giving them ice saline or cold saline, this one will be warm saline. Okay? So the IV bags will be wrapped in warmers. Instead of lavaging them with cold, we're lavaging them with warm solutions. Okay? We monitor the same things, especially the ABGs, because the blood, you saw what happened in malignant hyperthermia. The patient went into acidosis. So it'll be the same thing here. So both extremes of temperatures will cause metabolic imbalances, particularly which will be reflected in your arterial blood gases. So the blood pH will change here because whether it's too hot or too cold, cells die either way. Does that make sense? So you're dealing with similar metabolic disturbances here. Your interventions, of course, will be opposite. All right, so here is a list of rewarming strategies. So you have, if it's, let's say, somebody falling into on thin ice, so therefore you remove all the wet clothing, because the longer they stay on, then the cooler the patient gets. So take them off, replace them with warmer clothing. Put blankets, anything you can use to, whatever is available. Let's say there's a fireplace, so put them near there. If you have heat lamps, then do so. One thing to note is this is now warming. Okay, so please be careful about oxygen. Let's say you're giving oxygen plus there's a fireplace nearby. Okay, so just use common sense. Those are dangers. But with warming O2, we use up to 40 degrees at least. So how do you exactly warm oxygen? Jasmine, how do we warm oxygen? Do we use a humidifier? All right, so it's the humidifier that you warm up. Okay, so the oxygen goes to the humidifier, and it's the humidifier that you warm up. Okay, of course, oxygen is combustible, so we can't expose it to fire. And then same thing, we warm the IV fluids as we infuse them. And here are other means which we already discussed in malignant hyperthermia, but only the opposite. Instead of putting in cold, we're using warm solutions. As far as if the patient doesn't respond to any of your interventions, this will be a last resort. ECMO is more used for children because it's easier to set it up in kids. I'm not saying we can't do it for adults, but it's more for kids. This is externally warming the blood. So we'll put 2 IVs in the patient. One removes blood, puts it into the ECMO machine, and then it's warmed while in the machine, and then the other line returns the blood to the patient. So this is similar to a heart-lung machine during open heart surgery. If you're familiar with coronary artery bypass graft, the open surgery we use. So we use a heart-lung machine. Of course, the purpose of the heart-lung machine was to oxygenate and circulate the blood. This one, the ECMO, is going to warm the patient. Okay? and also oxygenating the blood at the same time. Please read this safety alert. It's long, but the gist of cardiac arrest is, if you read the whole thing, it will tell you that normally, how long do we do CPR? Meaning, after, who are EMTs, paramedics here? How long do we do CPR? Like, you know, when we say, you know, it's time to stop, and it's pointless.
30 minutes, isn't it?
Is it half an hour?
20 minutes.
That's too long.
20 minutes.
Come on, well, how long is it?
I don't know. In an OR, I've seen it done more than an hour.
Professor.
20
Hey,
minutes.
did you guys do your CPR certification, or did you buy your
No, we
BLS card?
didn't. We did it with Swedish.
No, this is discussed in every BLS class certification or renewal.
We do it until the emergency people come.
Anyway, so I'll put that in the exam, right? So we're supposed to know that. Anyway, what this safety alert is saying is the patient who is hypothermic, especially if we're dealing with frostbite and all that, with severe hypothermia, the patient, the CPR will be extended. The CPR time will be extended because, for one thing, we may not have been circulating the blood very well if the patient's temperature is so low. So this is the reason why they extend the CPR time longer, because when you do CPR and then the patient's cold at the same time, we're not really, do you know what I'm saying? You're not circulating warm blood, you're circulating cold blood, which is not very well oxygenated. So therefore, when you do CPR and the patient's cold, while you're rewarming the patient, you extend the time, because the principle they're saying is nobody's dead until they're warm and dead. Do you understand that saying? Meaning you're not dead until you're warm and dead.
What does that mean?
Okay, so this only applies to a hypothermic patient. So here, cardiac arrest in a hypothermic patient. So when you're doing CPR, but then the patient is cold, they're not dead yet, because like I said, you're not really circulating warm, oxygenated blood. You're circulating, every time you're doing chest compressions, what you're circulating is poorly oxygenated cold blood, because when the hemoglobin is not at optimal temperature, they cannot hold on to oxygen. So you continue CPR until the patient is warm. Does that make sense?
Yes, okay.
Okay, so therefore
Yeah,
they're dead. Yeah, they're not dead until they're warm and dead. So until then, you continue CPR. Only for hypothermia, okay? In general CPR, yeah, I mean, they're warm to begin with, so they're dead when they're dead.
So is it half an hour?
I don't really, I don't want to say that, because you're circumventing here. You're asking me for the answer.
No, I think it's 30 minutes, Professor.
Because I googled it and average was 30 minutes.
Okay, let's see on the exam.
No, you can't do that.
You have to let us know before you test us on it.
Here. Okay, with another principle for rewarming technique is the after drop. Can someone please read what is after drop? Thank you, Miss Vangelica.
After drop is defined as a precipitous reduction in core temperature due to redistribution of body heat to improperly warmed peripheral tissues, with rapid shunting of cold blood from the periphery to the core as a direct result of vasodilation.
Okay, so based on this principle, Where should you start rewarming? The arms, the extremities, or the patient's trunk?
Trunk.
Okay, so you should start actively rewarm the core. Okay, the trunk should be rewarmed as a priority. I'm not saying you don't rewarm the extremities, but focus the rewarming on the core, right? That way, when blood circulates, you don't get the after drop. Okay, please read the rest of this safety alert. Let's go now to signs and symptoms. So a patient who is hypothermic, what will they look like?
Cyanotic.
Okay. Signs and symptoms, by the way, are here. Sorry. So the patient, what will happen to your heart rate? Going back to dysrhythmias last semester. So what are the causes of tachycardia, sinus tachycardia, and sinus bradycardia? What's it? Which one was caused by hypothermia? Which one was caused by hypothermia?
Wouldn't I start initially with tachycardia and then proceed to bradycardia?
Okay, but the tachycardia here will only be for a few minutes. Okay, so as when we find the patient though already hypothermic, what do you think the heart rate will be?
Bradycardia.
Bradycardia.
Yeah,
It's already
low.
all right. So the temperature, by the way, we're monitoring here must be core temperature. So you'll have to insert a rectal probe because we cannot rely on the oral or the tympanic temperatures here, or worse, axillary. So it has to be the rectal temperature for accurate monitoring of the patient's core temperature.
But wouldn't that stimulate the vagus nerves? And would it is they're already bradycardic, so wouldn't that also lower their heart rate or no?
Yeah, if you put the thermometer all the way up to their mouth from the
No, but if you're putting it through the rectus, don't you like
like I said, it's only 2 inches in there. Okay, it's not going to reach the vagus nerve. Okay, it's only in the rectal wall.
okay, so then.
Okay, so it won't go. Don't worry, it won't go that deep. So neurologic status will be, again, these interventions will go faster when we get to hyperthermia because we're really assessing the same things. Yeah. So neurologic status, whether it's hypothermia or hyper, it will cause changes or deterioration in the neurologic status. Lab values, again, ABGs will show acidosis, the same thing as in hyperthermia. And then there will be hypokalemia here initially, okay, but then later as the cells die, then you'll have hyperkalemia. Glucose will be also both, which will follow potassium, the pattern. Oxygen is your intervention's priority. Monitoring, again, the patient may go into cardiac arrest with severe hypothermia. IV here is not only for your medications, but also for internal warming. And these are your first aid. Okay, so you start these, well, except probably there. You can do these at the scene. You don't have to wait for the patient to reach the hospital before you start them. So you can start the rewarming techniques at the scene and also on the way during transport to the hospital. And then, of course, once we reach the hospital, then you have the rest of these methods. Is Tamara here? come there's 31? Who's in here twice?
Professor, it's Angelica. I'm here on my phone because my Wi-Fi is bad and you're breaking up.
Oh, so there's 2 of you in here. Okay, all right. And teaching will be, of course, to prevent the whole thing in the first place. Please read this thing about alcohol, because let's have Giselle read this, because I'm sure Giselle may have a different idea about alcohol and feeling warm.
I was like, Professor, did you call on me?
Yeah, like 15 minutes ago.
Stop playing. Alcohol may make a person's body feel warm inside, but it causes blood vessels to dilate, resulting in more rapid heat loss from the surface of the skin. Using alcohol or recreational drugs can affect judgment about the need to get inside or wear warm clothes in cold weather conditions. If a person is intoxicated and passes out in cold weather, the risk of hypothermia is high.
Okay, because popular belief is when it's cold, we like to drink, right? Because it makes us feel warm inside.
Yeah.
Linda, is that true, Linda? Or Gladys?
No, I don't drink. So.
Oh, okay. I mean, you know, what you've heard, you know?
Yeah,
Me neither. I don't drink either. Yeah. But I've heard that people feel warm when they drink alcohol, right? So it's actually contrary. All right, so here's the rationale. And that's it for hypothermia. Any question? Very good. Let's go to hyper. So hyperthermia, let's start with definition. So hyperthermia, if your body temperature is now 103, above 103. So before that, it's simply fever. Okay, so hyperpyrexia, which is fever. Hyperthermia is a different concept. Here, it has something to do with your thermostat setting. So the set point here is intact in fever. However, in hyperthermia, the set point has changed. I don't know if that makes sense. How do I explain this? Okay, so in fever, which is caused by an infection, the patient, due to the pyrogen is the organism causing the fever, right? So the pyrogen causes a change in your thermostat, in your set point. So let's say your set point is, let's say just hypothetically, is 98 degrees. Okay, so let's say the set point is like the thermostat. Okay, so let's say you put your house thermostat at 98 degrees. So of course, when the temperature goes higher than 98, what will your AC do?
It will set it back to 38.
Yeah, so it will kick in, right? It will turn on when the temperature in the house hits that set point. So let's say you set your house temperature at 98. When the temperature reaches that, then the AC will kick in. All right, so to drop the temperature. So what happens in fever when you have an infection is the set point changes. So instead of 98 being your thermostat setting, it will now go to a higher setting. So let's say the thermostat is now at 102. So therefore, when will your cooling measures or cooling mechanism start? Not until you hit 102, right? Or whatever that new set point is. Does that make sense? So
Yes.
that's it's, yeah, so that's why when you're sick, you have an infection, you're septic, the patient's temperature goes higher and higher because the set point has now changed. It is no longer the regular or the normal set point. It is now higher. So that's why it's harder for us to drop the temperature. In hyperthermia, there is no such change in the set point. The set point or the thermostat of the body stays the same, meaning it's normal. It's just that the patient's mechanisms here, heat loss mechanisms kicked in, but then the patient's heat loss mechanisms eventually fail because either we did not remove the patient from the environment causing the hyperthermia, or let's say they're out of reach. For instance, an example of hyperthermia is heat stroke. Before we hit his heat stroke though, the patient will undergo heat exhaustion first. Heat exhaustion is really basically, if you read the definition, it's basically dehydration resulting from high temperature. So let's say you are, I'll use Tatiana for instance. So Tatiana runs out, let's say yesterday or the day before. Wednesday was a really hot day, right? Because I was out Wednesday, it was pretty hot outside. It's really muggy. It was very humid. So when she went out running on Wednesday, and then she didn't bring any bottled water. You know, she was just running there. So she was producing heat from running. Plus, she was also exposed to heat from the sun and also all the humidity. So will her body temperature go high?
Yes.
Yes. Okay. As long as she reaches help though, so she will experience dehydration because there will be increased heat loss because her heat loss mechanisms will kick in, you know, the evaporation, you know, she'll be sweating a lot. So the dehydration there because of the heat will put her in a condition called heat exhaustion. But that's not heat stroke yet. If she receives treatment, so let's say she stops running, goes back home or goes under the shade, you know, fans herself, for instance, and then takes a drink of cold water, that will fix it. Okay, so she will not have heat stroke. Heat stroke is now a true medical emergency because what happens in heat stroke is either the patient did not receive treatment for heat exhaustion or have no access to the treatment. So, number one example of heat stroke is especially in the younger population. I mean, it's understandable in the elderly because you simply have to live in the desert, for instance, let's say out there in Arizona or in Nevada, for instance. Okay, those are really hot places. That's easy there. But for a young person to suffer heat stroke, for instance, that's unlikely, correct? So one cause of heat stroke in younger patients are in, let's say, a marathon. So let's say in the middle of summer, July, August, you run a marathon, and then there's a stretch of for how many miles, for instance, wherein there are no water stations. Okay, let's say the organizers messed up. Okay, they didn't have um, any EMTs or any hydration stations for a good 2 miles. Okay, they messed up, or they put somebody there, but then those assigned to that station didn't show up. Okay, so for a long stretch there, the runners didn't have access to Gatorade, okay, because you need some hard water here. You need water with electrolytes. So let's say a long stretch wherein they did not have any cooling measures. All right. So
Professor,
that's an example there of heat stroke because now you're unable to um, your heat loss mechanisms now fail. They cannot keep up with your heat loss because either you did not have anything cold to drink, so the temperature in your brain specifically, in your body temperature reached so high that it now messed up with your cognitive function. So there will now be mental status changes, you get confused, and then once confusion sets in, are you still aware of what you need to do?
No.
No more.
No.
You go crazy, and then now you're disoriented. Now you now wander off somewhere, and then let's say you're in the desert, for instance. So that's when people get lost and then die.
Wouldn't you faint first or something like that?
Yeah.
Because that actually happened to my nephew. He's a Marine.
What was the question again?
Wouldn't you faint first? Like, because so it happened because of heat exhaustion. Like he was running for training, and he passed out, and so that's when I guess the sergeants and all of them, they found out it was that for hypothermia.
Okay, so if it is heat exhaustion, though, remember I said heat exhaustion is basically dehydration from heat.
Mm.
Okay, so because the temperature is so high, and then you got dehydrated. So basically, that person, when you pass out, then that means it's no perfusion to the brain. That's why it caused the patient to pass out.
Okay.
But it's not, but that's not heat stroke though. Heat stroke is now the temperature will be similar to, well, not as high as malignant hyperthermia, but close to it. Like you're already at 106, 107, 108, those temperatures right there. That's now heat stroke.
Okay.
With hyperthermia, it's simply here around 103. All right, so that's hyperthermia right there. But when you hit heat stroke, again, although some patients still have sweat, they still sweat when they get heat stroke, but most people don't, meaning their heat loss mechanisms completely fail now. And look at the risk factors, so very similar to what we read in hypothermia. So I'll just go over that. I'm not testing these because really the mechanism will be similar, whether they say heat stress, heat edema, heat cramps. These are more specific causes now. So let's go here. So this is the heat exhaustion we were talking about, which is basically dehydration. If you read it, it's dehydration caused by heat. So the test questions will be on heat exhaustion versus heat stroke. These are really the common terms you'll see on the NCLEX. So most of our patients will either have heat exhaustion and or heat stroke. So most heat strokes will start with heat exhaustion first. So if not treated, then the patient will go into heat stroke. So either they don't have access to the liquids, to the fluids, or they're not removed from the cause. So heat stroke there are two possible causes here, either environmental, meaning you're just out there in the sun or inside a really hot room or house, or it could be exertional related, meaning from a marathon. Okay, so the heat stroke is from the heat waves that hit our elderly specifically, and the others are exertional heat stroke. So this is from sports, usually sports related. It's also one of the complications is rhabdo. Still, this one is related to the exertional heat stroke. Management will be internal and external cooling measures. We have a rule here, though, that when we cool the patient, we stop the cooling measures, the aggressive cooling measures, when we hit 102. Because this is now under 103, so therefore your set point is now back to normal, meaning you're close to your set point. Because if you continue the cooling measures at 102, I'm talking about hyperthermia, okay, not fever. Are we clear about this one?
Yes.
Okay, so we're talking about hyperthermia here. We're not talking about fever. For fever, yes, we continue cooling way beyond 102. But when we're talking about heat stroke, heat exhaustion, hyperthermia, we stop the cooling measures once we hit 102. Because once we hit here, you will activate shivering now, which is now counterproductive. Because if you continue cooling, but then the patient starts shivering, what will happen to your cooling measures? Because remember what shivering will do. It will
heat.
Create heat.
Yeah, it will produce more heat. So we stop. So once we hit 102, then you can stop your cooling measures. You can now give antipyretics now. Because here, if it's high, if it's either heat stroke or heat exhaustion, Tylenol will not do anything here because the rise in temperature here again has nothing to do with any change in the set point. Okay, unlike in fever caused by infection, okay, wherein there's a change in the set point. That's why we give antipyretics. So if you notice here in the interventions, here under management, there's no Tylenol mentioned here. Okay, we only do fluids and then cooling measures. Now the as far as to prevent shivering here, this is the only drug we give. So you give either lorazepam or diazepam, okay, to prevent shivering while you're cooling the patient. And
so Professor, we don't give any meds until they reach that set point, right? We just do liquids and
yeah, and then cooling,
and the cooling. Okay.
Yeah, cooling measures. Because really, there's no infection involved here. Okay, the temperatures, the patient's body temperature just rose because of the cause, which is usually environmental in nature or exertional, right? There was no pyrogenic organism involved here.
Got it.
Yeah. I mean, you can give Tylenol, but it's not going to work.
No, what about Motrin?
Same thing. Again, the nature of hyperthermia is it's not because of a change in your set point. Meaning the reason why you had fever was because the pyrogen caused a change in your set point. It now, instead of your body thermostat at, let's say, 98 degrees, I don't really know what, but let's say it's your body temperature is set at 98. Now the pyrogen, the organism, caused the set point to change to 101 or higher. So therefore your body temperature adjusted to that new set point, and that one can be treated with Tylenol. So here, the cause in hyperthermia, the temperature rise here, the set point never changed. Your set point, your thermostat in your body was still at normal 98. It's just that either in exertional hyperthermia or exertional heat stroke, your body was just, your muscles were just exerting for such a long time that you produce so much heat and energy. Whereas, plus if you add environmental temperature there, that will increase your body temperature higher. But again, the set point of your body never changed. The body temperature just got so high that your heat loss mechanisms can't keep up with it. Meaning you can only sweat for so long, right? Yeah. So then of course the longer you sweat, then the more fluids you lose. You need to keep replacing that. But because in heat exhaustion or heat stroke, you had no access to that fluid, or you did not you were not aware anymore, especially if you develop heat stroke wherein you have mental status changes now, so you don't know what to do, you get disoriented, confused, and then you die.
Got it.
Severe dehydration. Okay. And that's typical. When I was still living in Florida, yeah, some of my neighbors, we get frequent, we call the EMS frequently because they just pass out in the yard. Where these are 80, 90-year-old patients, and didn't they have no children around, so they continue mowing their 1 or 2 acre properties themselves, and the whole time they were out there in the sun, and they just pass out from dehydration. And that's it, boys and girls. Any questions?
No.
All right. Give me 5 minutes and then I'll start the exam review. Okay.
Okay.